Good evening. I think we'll get started. Welcome, everyone. My name is Kevin Gassemi. I work in the Division of Digestive Diseases here at UCLA, and I will be the moderator for tonight's event. And it's my pleasure to introduce my colleague, Dr. Eric Esrailian, who is co-chief of the Division of Digestive Diseases here at the David Geffen School of Medicine at UCLA. He received his degree in He received his degree in integrative biology and a minor in English at the University of California at Berkeley. He then got his medical degree at Loma Linda University School of Medicine and subsequently attended the University of Southern California, where he completed his residency in internal medicine. Then he came to UCLA and completed his gastroenterology fellowship. At the same time, he achieved a Master's of Public Health degree and also completed the Executive Program of Management here at the UCLA Anderson School of Management. He also was a previous member of the Medical Board of California. Dr. Esrailian and I work closely together in the Division of Digestive Disease Clinical Programs, and it's my pleasure to introduce him now, and I will be back at the end to help field questions. Thank you.
Thank you, Kevin. I apologize, I'm stuck back here. I'm not mic'd up, but if I don't speak loud enough, don't hesitate to shout at me or whatever. I'm happy to make this a very interactive process. That's what I'd like. I'm so impressed by the turnout. Thank you so much for attending. I think it's really exciting to have a chance to do these mini medical school sessions, and we'll try to make it as much as a mini medical school experience as we can. So at the end, when we have opportunities for question and answer, let us have it, okay? As Dr. Gassemi mentioned, my name is Eric Esrailian, and I work in the Division of Digestive Diseases. This session is topic, heading is alternatives to surgery. So I've tried to keep that in mind as we go through the slides, because you are going to have a few other sessions for those of you who are going to be attending the other sessions, and I'm trying to set the stage for some of those sessions, although the topics might vary. So what we're going to do is discuss some of the alternatives to surgery from a gastroenterology perspective, and that's what Dr. Gassemi and I are. We're gastroenterologists, and I'll talk to you a little bit about what that actually means and what our specialty is about. Spend a little bit of time in background, and I think for first-year medical students, which is what I envision you all to be right now, you really have to get a sense. Actually, I was spending time with a first-year medical student today, and it's such a wonderfully exciting time in the career of a young physician. And this student was particularly enthusiastic, which I love to see. And I thought about you. I actually told him about mini medical school this evening at UCLA. And I think that the experiences that medical students learn through clinical, practical applications, or going and seeing observations, or actually just learning in class, are really different than the real world experience of being a physician, trying to make a decision. I had a professor when I was in my residency who said that MD stands for make decisions. When I was hedging about something, I said, well, I don't know, we could do this, we could do that. He said, Esrailian, make a decision. So I keep that in mind, and we'll talk a little bit about the medical decision-making process. And we're going to go through a few cases focusing on specific areas of the digestive tract where there are interactions between medicine and surgery. So I don't believe Dr. Dutson is going to focus on these exact things, but these are areas where we have a lot of interactions with surgeons as colleagues, and patients are put in a situation where they have an opportunity to either get a medical treatment or a surgical treatment. So we'll talk about that, and then eventually we'll go and do some question and answer. So as I mentioned, this is part of a series, and the next session is going to be on anesthesia issues, and finally on surgical issues. So I think you can keep that in mind as we go through some of the slides. I think, again, as a first-year medical student, I want you to think about the evaluation of a patient. Many of you might have been a patient at one point or another, or you have family members that are. So all of us have had the patient experience in one way or another, either directly or indirectly. And I think it's important for physician trainees to keep that in mind when they're talking to patients and thinking about making decisions. We're going to go over some general themes in medicine, and I'll try to focus on a few specific cases. And like I said, from the medical perspective, I'll tell you about what gastroenterology is. We're kind of a specialty where we do procedures in the midst of our patient care, so there is a procedural aspect to it, but we are internists, and I'll explain what that is. But we're going to take a 30,000-foot view, really a global picture of what it is to be a gastroenterologist and think about alternatives to surgery. And as I mentioned, there are paradigms in other fields. In cardiovascular diseases, there are medical options and surgical options, and that applies to a lot of areas of medicine. So how many of you know what a gastroenterologist is? Can you raise your hand? Okay, so most of you do. So in our institution, we also call it digestive diseases. So that's really what gastroenterology encompasses. People typically think of it as gastroenterology and hepatology. Hepatology is the study of liver diseases. And really, everything in the digestive tract is covered in gastroenterology: the esophagus, stomach, liver, gallbladder, pancreas, and small and large intestine. And you've probably heard people say lower intestine, upper intestine. But the small intestine is basically called the small intestine. It has 3 different parts. And the large intestine is also known as a colon. And the very end of the large intestine is called the rectum. So that's why colon cancer is sometimes called colorectal cancer, because they're often grouped together, even though the treatments might be a little bit different. So you're all in the beginning of medical school. So this is your mini medical school experience. If you were going to go to medical school, you would have done undergraduate degree in college and then completed 4 years of medical school on your road to being a gastroenterologist. Then you will have done usually 3 years of internal medicine residency. And then after that, you do something called a fellowship in gastroenterology. And typically it's 3 years of training, but it can be more depending on the area of sub-specialization. So there are some people who do advanced training in more complex procedures, and there are some people who do advanced training in something called transplant hepatology. So that's the care of patients who need liver transplants before and after transplant. So it's a long road, as you can see. So I hope I haven't talked any of you out of it. All physicians kind of think that their specialty is the most interesting. So Dr. Gassami and I happen to think that digestive disease is particularly interesting. So we encourage all of you to pursue this if you make it to year 2. So another thing about gastroenterology that I think is important to think about is the combination of being an internist and somebody who does procedures, because oftentimes patients might think of us as the doctors that do the colonoscopy or the upper endoscopy, but a great majority of the time that we spend with patients is in the outpatient setting, just like another internist, and really thinking, and as some of my colleagues say, using cognitive skills, not just procedural skills. So that's why I think it is a really interesting specialty, because you have the opportunity to care for patients in all types of settings. So this is just a basic diagram of the digestive tract. And since I don't have a pointer, I'm going to use the mouse here. But this is the esophagus, or the food pipe. Comes down to the stomach, and the stomach curves around. And then we have the small intestine attached to the stomach. And the small intestine and colon are actually quite long. The combination is over 20 feet. And so this is all packed very tightly in the abdomen. So there's not a lot of room to go, as you can see. And this is the liver, and the gallbladder is right there under the liver, and the pancreas actually lays right in there. So digestive diseases encompass a huge part of a person's anatomy. Does anyone know who this is? I don't expect you to know. I actually found this picture, but this is actually Hippocrates. So the reason I put Hippocrates' picture in this slide is because Hippocrates is one of the most influential physicians in the history of modern medicine. And I'm sure many of you have heard of the Hippocratic Oath. When you graduate from medical school, you will say some version of this oath. Most medical schools have a physician oath as part of graduating. And I think there's a lot of mythology around some of the specific terms. But one thing that Hippocrates was influential in is establishing some focus on the patient when it comes to being a physician and some of the ethics of being a physician. And I think that some of the medical decision-making that we're going to talk about as part of this alternatives to surgery concept really dates back to the era of Hippocrates, because Hippocrates was actually considered kind of an outcast for some of his beliefs back in those days. He actually served a prison sentence as well for some of his beliefs. So I just wanted you to kind of keep in mind that this is a relatively newer concept in the history of the world. So let's talk about what a patient evaluation is, because I think when you're thinking about alternatives to anything, you're going to weigh one set of possibilities versus the other. So the very basic patient evaluation is typically called a history and physical. And many of you probably haven't heard the little abbreviations that doctors use or trainees use, but we typically call that an H&P, history and physical. And that's a really critical aspect of any patient interaction. When you go see a doctor, that's actually what the doctor is doing for the very first time, asking you specific questions, and I'll go through those, and then doing a physical examination. As part of our cases, we're going to go through a few brief cases. We're going to also look at the possibility of getting diagnostic information, thinking about different treatment options. And really, you always have to weigh risks, benefits, and alternatives. So as part of this series of alternatives to surgery, we're going to think about all the different possibilities that a patient is going to encounter. And as a physician or any healthcare provider, what are you going to help the patient with? Because that's really what one of our jobs is to be an advocate for the patient and help the patient make a decision. Ultimately, I'm going to kind of sound like a broken record sometime, but one size did not always fit all for patients. So even though there are certain guidelines that we like to follow, patients will often have a relative or a friend who's gone through something similar. They'll say that so-and-so received this kind of treatment, and that's probably true, but we have to think about what the situation is for that individual patient. And I'm going to touch on something called evidence-based medicine in a second. So this is probably a real t-shirt. It's actually for sale on the internet. But evidence-based medicine, you might think, well, that's common sense. I mean, isn't that what doctors should be practicing, evidence-based medicine? But much of what a physician will end up doing is based on his or her own personal experience after a certain point. So after you guys all graduate and you're working in the real world as a physician, there might come a time where you say, well, I've seen this case time and time and time again, and I know what I'm going to do. But really, the medical literature is a living and breathing body of data. And we frequently have to go back to the medical literature to establish whether or not certain things are true. And so much of what we've learned in medical school is based on a lot of experience. But if it's studied in objective studies and published time and time again, it builds up this body of evidence-based medicine. And so there are certain factors that make up what evidence-based medicine is, but we try to stress that to our trainees these days to make sure that they're not making decisions or informing patients just about things they've heard or something that was passed on by a doctor without actual data. So that's really important. So what are the factors that, or the features that make up an H&P, history and physical? So the first thing that you're going to encounter in some of our cases is the chief complaint. So the chief complaint is basically why the patient is there. So how can I help you today? So sometimes patients will come because their primary care doctors referred them and they don't even know why they're at the subspecialist's office. And you might find that hard to believe because it takes time. You need to go park, you need to make an appointment, you need to take time off of work. But that's really important because as a practicing physician, you should at least address the reason why a patient is there. And if there's a referred patient from another colleague, you want to answer the question that the colleague is seeking help for. So I think that's really important. It seems very simplistic, but it's important to kind of get that out of the way in the very beginning. And there are very specific things that a doctor will ask, particularly in the first visit. And so we'll go through some of those. The past medical history and surgical history. Has a patient had any kind of high blood pressure, diabetes, any other chronic medical problems, any surgeries, which is very relevant if you're dealing with digestive disorders too? Has a patient had their gallbladder removed or appendix removed? Any history of colon polyps, etc.? Medications. What medications is the patient on? Patient have any allergies? So not just food allergies, but specifically drug allergies. You have to be very careful about drug allergies, particularly if you're going to prescribe anything, and think about drug interactions. Family history is critical, not just mom and dad or brothers or sisters. Those are first-degree relatives. We really care about first-degree relatives a lot because that has a lot of potential genetic predictors for an individual person, but also grandparents, uncles, aunts, cousins. This information is helpful. And sometimes if you're just going for a runny nose, maybe it's not that relevant. But if you're evaluating a person for possible colorectal cancer and you need to make recommendations about how often a person should be screened, that's an important question to ask. So oftentimes medical students will kind of take a very quick history and physical, or they do the opposite. They take a really long history and physical, which is good because it's much more detailed and we want people to be thorough. The social history is relevant as well. Does the person have a history of tobacco use or alcohol use, and how frequently? Because we know that tobacco and alcohol can have a specific impact on the risk of cancers, different kinds of cancers. And other features of the social history that could be relevant is whether or not the person lives alone, what's the support system. This might influence your decision-making when we're thinking about these alternatives to surgery. If we're going to refer a patient to surgery, does that patient have any support? Can someone actually bring them and care for them after the surgery? This all kind of is something you need to think about. Even when we have people come for colonoscopies, if patients don't have a support system, sometimes they can't have a driver bring them for a colonoscopy. And frequently we encounter people who say, I don't have anybody that can bring me. And that's why it's really important to kind of really get an understanding of what's going on in a person's life. The review of systems is a general review going through all the different organ systems, neurologic, cardiovascular, pulmonary, asking questions about active symptoms now. Gives you a better a window in terms of what is going on with an individual person. And finally, the physical examination as well. So we actually teach in medical school, and it actually, I find this to be very true. A very careful history and physical can really narrow down what's going on in a patient. And that's called a differential diagnosis. A differential diagnosis is basically what are all the different possibilities that you think about. And eventually, once you do this enough, your differential diagnosis will be more focused. It could be literally anything under the sun, of course, when you first start. But after a certain amount of proper questions and physical examination focusing on specific aspects of that patient, you can narrow things down and get to kind of the most likely candidates in terms of a diagnosis. So let's kind of turn our attention now and focus on a case. Now this could be any patient that Dr. Gassemi and I see in the office on a regular basis. So this is an esophageal case. And these are not like House, the TV show, mystery cases. These are going to be cases that I think we encounter pretty regularly. And then we have to think about medicine versus surgery, or maybe the combination of both. So that's why I think they're kind of fun for us to think about today. So this is a 38-year-old man with indigestion. So unless you've actually had indigestion, nobody even knows what that means. But if you've had it, you have an idea of what it means. Just basically discomfort, and basically can be pain or pressure in the upper abdomen. This patient says that he has burning behind the chest. So some people call that heartburn, although it's really not related to the heart. It's in the digestive tract. But it can be alarming sometimes because people who have chest discomfort worry that they might be having cardiovascular symptoms. The gentleman says that the symptoms are worse at night and after meals, and has a bitter taste in his mouth. Occasionally he has hoarseness, dry cough, and throat clearing. So here's a little trick that you might notice, that people who constantly are doing this might have this condition that I'm going to show you. And the patient also mentions that he had recent weight gain after a sports injury. So I kind of stacked the deck here. These are all things that can potentially cause our condition, and that condition is gastroesophageal reflux disease. So like I said, this wasn't like the television show House. This is actually one of the most common diagnoses that we see in gastroenterology and even in primary care. Most patients actually go to their primary care doctor first for these symptoms and don't go directly to a subspecialist. And really what reflux is the juice from the stomach, and that's called gastric juice, but I put stomach juice on here, refluxing back, coming back up into the esophagus and causing discomfort. Now the stomach is basically an environment that is accustomed to high acid situation. So the stomach can handle acid. The esophagus doesn't like acid very much, so that's why people get discomfort. So we all have some acid in our stomach, and some of us are refluxing right now. So everybody's going to be aware of it in the moment. But babies reflux because it's easier for the juice to come up in a baby. But the esophagus, like I said, it does not like reflux as much. And the vocal cords and the throat really don't like reflux. So that's why people who get reflux all the way up to their vocal cords can get hoarseness. And if they actually get tiny particles of acid into their lungs, that's called aspiration. And that irritates the lungs. So people get frequent cough related to that and can even develop, in the worst cases, even pneumonia related to aspiration. And that's kind of an extreme situation, but just wanted to kind of point out that the juice in the stomach is really meant to be in the stomach and maybe a little bit of it refluxing up. Once it starts to reflux to a point that it bothers a person, that's when we often take notice. And heartburn is really the symptom that a person experiences. Reflux is actually what's causing that symptom. And sometimes we think a patient has reflux, but they really don't. There are other things that are causing it. So for the purposes of this case, we'll just say that the patient has gastroesophageal reflux disease, and GERD is the abbreviation. So typically as doctors, we think about all the different possibilities on how to treat this condition. The most conservative and sometimes the most appropriate thing to do is think about lifestyle modification. So we'll talk about that. Then there are different medications that a person can take to alleviate the symptoms. And then finally, there are surgical alternatives. And we're not going to really talk about the surgery options today, but I will kind of touch on them, and we'll think about that in each case. So the most common triggers for patients with reflux really are anecdotal. Remember we talked about evidence-based medicine and thinking about what's the largest body of evidence. This is something, these trigger foods have really developed because people have experienced them over decades. Many doctors have experienced them themselves. I often see patients who have gone to a doctor's office and have been given a handout about an anti-reflux diet. And really, that can change depending on the individual. So what stimulates reflux in one individual is not always the same from person to person, but it doesn't hurt to consider potential trigger foods and potentially eliminate them from the diet. So common trigger foods are spicy food, alcohol, tobacco, tomato-based foods, and there are potential physiologic things that happen in the lower esophagus because of these foods. And sometimes people can actually overeat. So if you eat a large meal, there's more contents in the stomach, and it's more likely that some of that stuff will come up and cause a person to have symptoms. The reason that nighttime people often have symptoms is most people are sleeping at night and they're lying on their back. So having the contents reflux at night is much more common because when somebody's on their back, gravity is working against you and you can actually reflux contents more easily. And weight gain can actually exacerbate symptoms, which is why I mentioned the sports injury in the case. And patients who become pregnant oftentimes experience symptoms at different trimesters of their pregnancy. And definitely in the third trimester, patients frequently mention reflux symptoms to their doctors. So lifestyle modification can work well for some patients. Some patients can do all the things I mentioned, including elevating the head of their bed, sometimes putting the bed on blocks, not eating at all before bedtime. But all the things that they do don't help them with their symptoms. You can actually encourage patients to lose weight if possible, but it's easier said than done in some people. And many patients are debilitated because of this symptom. I mean, it can really impact a person's quality of life. Actually, quality of life scores are questionnaires that doctors and researchers often give patients. And patients rate gastroesophageal reflux disease as one of the most significant conditions that impacts their quality of life. So even going through lifestyle modifications might not help all patients, but it's definitely something worth considering, even if you're going to consider a level up with medication. So I'm sure all of you have seen a commercial related to one of these options, or even taken one of these medications yourself, or even had a relative do that, because it's so common to have experienced reflux symptoms. And they're among the most common over-the-counter medications and among the most common prescription drugs. So antacids are usually a first-line type treatment. So I'm using brand names up here just because I think that some of the trade names, usually in medical school, we do the opposite. We focus on the generic names, but I think many of you have heard of Tums or other kind of antacids, which basically try to neutralize the amount of acid in the stomach. They're actually not treating the underlying problem. Then there are two classes of medications which were really a breakthrough over the last few decades, which have completely revolutionized the way patients have ulcers treated or have reflux symptoms treated. But there's a first class called histamine 2 receptor antagonists, or H2 blockers. And those are drugs like Zantac and Pepcid. And then there's the other class of medications which are now over the counter as well, but there are many prescription options. And those are called proton pump inhibitors, or PPIs. And proton pump inhibitors include a group called Prilosec, which was the first one that came to market, or Prevacid. And the Prilosec is omeprazole and Prevacid is lansoprazole, respectively. These are very effective medications, and they're generally considered safe, although, of course, with all medications, there are potential risks and benefits, and that's why it's really important for a patient to have a dialogue with his or her doctor to be able to figure out these risks and benefits for their individual situation. With proton pump inhibitors, for example, or acid suppression in general, risks may exist with respect to bone density, for example. And many of you might have read about the impact of bone density from proton pump inhibitors. So although the actual impact on fracture risk is not clear for all people, these are still medications. Even though they're over the counter, they are pharmacologic medications and need to be discussed with a physician. And that's why if you look at the package inserts or directions on these packages, they won't just say, take these forever. They all say, take for 7 days. And so patients often say, well, it said only take it for 7 days. It's mainly because people don't want you to be taking these on autopilot. They want you to have some sort of dialogue because they could be masking symptoms of something more serious. If a doctor says, okay, I want you to take this for 12 weeks, then he or she has probably considered all those serious options and then made that recommendation. So really, kind of the recurring theme today is going to be focusing on the individual patient. So there are surgical options for reflux, and I'll kind of explain one of the snapshots in terms of what a surgical option would be. But you always have to think about the individual person and what is potentially causing that person's symptoms. There's something called a hiatal hernia, and I'll show you a diagram of what a hiatal hernia is. And patients often say, like, I feel my hiatal hernia. It's probably not true because a hiatal hernia is not the same thing as an inguinal hernia, which is the type of hernia often people might need to get fixed after they've lifted a heavy object. A hiatal hernia is just kind of one part of the body kind of protruding into another part of the body. And hiatal hernia makes it more likely for patients to have reflux. But you have to think about the age of a patient. Someone who's 95, you might not recommend surgery for because of the risks of surgery. But someone who's 18 and potentially is looking at a lifetime of having reflux symptoms, you might consider, or taking medications over the course of a lifetime, we might consider surgery in certain circumstances. You have to think about the clinical condition of a patient, because if a patient is doing very well, it gives you a lot more options in terms of how you're going to treat the person. But there are people who are in the intensive care unit, for example, and have reflux symptoms. In those situations, reflux might be a minor back burner issue, and you're just going to treat the patient. One thing to consider is whether or not the medications are actually doing anything. And if they're not, you have to think about, is this actually reflux at all? Dr. Gsami and I kind of go through this on a regular basis with patients, is because patients will say, I've taken this, that, the other thing, but it hasn't really helped my symptoms at all. So usually, if people have an acid-related problem, if you give them something to block acid, it makes them feel better. Unless there's something else going on, like they have again, this thing called a hiatal hernia, which I'll show you a picture of, that makes it more likely or makes the patient more susceptible to have reflux. So you always have to think, do I really have the right diagnosis as part of this decision-making process? And one thing to factor in here, for example, is that many patients who get a surgery to help them with their reflux ultimately still need to take medication in the future. So in part of your discussion with the patient, you have to say, well, what about the fact that you could have a surgery, but within a year or two, you might still need to be on medicine. So if avoiding medicine is the only reason for the surgery, that might not be a good enough reason. So this is the hiatal hernia I was mentioning before. So I have my mouse here. So usually the stomach is entirely below the breathing muscle, which is called the diaphragm. And in the situation, and the breathing muscle goes up and down when you take a breath. Now in a hiatal hernia, part of the top of the stomach is actually protruding above the diaphragm. So instead of having more of a tighter seal, it's not really a seal, but we just kind of say that because intuitively it makes sense. But instead of having a more narrow lower esophageal connection, we call that a sphincter, the hiatal hernia makes it a bigger channel. So you just have a wider opening, and it makes it easier for contents from the stomach to reflux back into the esophagus. So basically, when someone has an anti-reflux surgery, the doctor often folds over part of the stomach and pulls the stomach down to create what it's considered a fundoplication. That's when this is folded over. So in patients with reflux, you really have to think about whether or not a fundoplication or repair of this hernia is actually going to make a difference. So does anyone know about Goldilocks and the Three Bears? So you thought you were at a very fancy medical school. But the reason I mentioned Goldilocks and the Three Bears is, if you remember this story, Goldilocks is eating the porridge and trying the different beds, and one is too cold and one is too hot, and then one of them is just right. So I think about that when you're evaluating patients for anti-reflux surgery. Because if the doctor makes that wrap too tight, then the patient can't swallow. So that's a big problem. So you took a patient who was a healthy patient who just had reflux, and now they have difficulty swallowing. What about the opposite problem? If you make it too loose, you basically didn't do anything. So you took a patient who had reflux, they went through the whole process of surgery, then the whole process of recovery and all those risks, and basically now it's exactly the same. So for anti-reflux surgery, there are a lot of factors to consider. The patient, the skill of the surgeon, the experience of the surgeon, because you want the surgeon to be very comfortable with that wrap, for example. So it's just a brief window into some of the complex decision making, because you'll often encounter patients or even friends of mine who will say, oh, I just want to have surgery and get that over with, as if it's just this all or nothing, flip a switch and everything's going to be fixed. But we really have to think carefully about surgery. And as much as skilled as our surgeons are, it's still a surgery that has risks, and so you have to weigh all this carefully. So let's move on now and think about another part of our digestive tract, which is the stomach. And all of us have used expressions like sick to your stomach or butterflies in your stomach. And sometimes that's because there's strong connections between the brain and the gut. And actually, many of my colleagues in our division spend their careers really researching these connections between the brain and the gut. So here's a case that's not just about brain and gut, but this is about a real thing that can develop in a person's stomach. So a 67-year-old gentleman presents to the doctor with black stool for 4 days. And in first year of medical school, you learn a huge amount of vocabulary. So this is your first word that you'll impress all your friends. It's called melena. So melena means black stool. And that means there's blood in the stool, okay? And usually blood coming from the upper GI tract looks black by the time it comes out. So this patient ultimately gets diagnosed with an upper gastrointestinal bleed. Something is called a CBC is done, which is a complete blood count. And it shows that the patient is anemic, which means their blood count is low. And they also have a low amount of iron, which is in blood. So we can measure that. And when someone has iron deficiency anemia, we have to think about the fact that they potentially have been losing blood for either a short amount of time if it's acute or a long amount of time if it's chronic. This patient, so happens, has not had any other symptoms. No weight loss, no abdominal pain, has not been feeling full as easily. If someone has been feeling full easily, you worry about a large mass maybe that could be in the stomach and is blocking their ability to eat and digest food. So the patient's referred to a gastroenterologist for an upper endoscopy. So I just wanted to use this as a quick segue to tell you about what endoscopy is. So as part of the field of gastroenterology, if you're thinking about alternatives to surgery, we do procedures called endoscopy, where we use scopes, which are devices and instruments that have cameras at the end of them, and we look into the GI tract, either from the mouth or through the bottom of the GI tract, through the anus and into the lower GI tract. And as one of our colleagues, Dr. Weinstein, often used to say, that endoscopy is part of the physical exam often in gastroenterology. Now, to a certain extent, that might be true, and in other situations, it might not be true. But we use endoscopy frequently when we feel like we can make a diagnosis by looking into the GI tract and identifying a potential problem. So in the upper GI tract, basically, patient will be typically sedated. Sometimes there'll be deeper anesthesia used, but typically it's the type of sedation which other people might call twilight. We call it moderate sedation. I mean, it's a combination of narcotic medication and anxiety medication that creates a state of sedation. And we go through the mouth, into the esophagus, down into the stomach, and then look even deep into the small intestine to identify problems and potentially sometimes even treat problems. So I picked a diagnosis that has an interesting combination or nexus between medicine and surgery. And I picked a disease, a tumor called a gastrointestinal stromal tumor, or GIST. And many of you might not have even heard of this, and many medical students might not have even heard of it. But a gastrointestinal stromal tumor is a tumor that grows in the lining of the gastrointestinal tract. It often grows in the stomach or in the small intestine. And when it grows over time, it can actually ulcerate and bleed. So this gentleman had a gastrointestinal stromal tumor, I keep saying stromal tumor, or GIST, that ulcerated and bled. Now, when they get big enough, or if they're in the small intestine, which has a really more narrow caliber or diameter, it can actually cause obstruction. So sometimes patients just present with obstruction. Other times they present with bleeding. When they're small enough, people don't even know they're there, and sometimes they're picked up on incidental endoscopies. Like somebody might have an endoscopy for reflux, like our first patient, and then the doctor sees something bulging out of the stomach wall. And when we take tissue from a lesion, is another anatomic word, something that's growing, we call that a biopsy. So a sample of tissue is called a biopsy. And when you biopsy something, you send it to a special doctor called a pathologist who looks at that under a microscope and helps you with a diagnosis. So that's an important part of diagnosis in gastroenterology. We work with pathologists, and we also work with other types of specialists called radiologists. And those are the doctors that look at x-rays, CAT scans, MRIs, and they specialize in actually reading that image. So you can see that we put a lot of faith in terms of our diagnosis in the pathologist or radiologist. So these are really important doctors, and we're very fortunate to have outstanding radiologists and pathologists at UCLA, particularly in the areas of gastrointestinal radiology and pathology. So gastrointestinal stromal tumors are very specific types of tumors. They often occur because of a genetic mutation that allows them to keep growing, these cells to grow, and they grow into a tumor that becomes visible to somebody doing a procedure. There are multiple genes that can be involved, but usually when the doctor, usually a gastroenterologist, takes a biopsy and sends it to the pathologist is the one that orders that special type of testing to see if a mutation is present. Most cases are not inherited, so they're not familial. which is sometimes disturbing for patients because, like, they say, I don't have a history of this in my family. But most people who have these GIST tumors don't have a family history. And usually at that point, another medical specialist called an oncologist will get involved, and ultimately a surgeon as well, because surgery is one of the definitive ways of treating GISTs. So a medical oncologist, just as a digression, is another type of subspecialist in medicine. So just like we're gastroenterologists, we did internal medicine residency and then gastroenterology subspecialization. Medical oncologists do internal medicine residency and then focus on hematology, which is a study of blood disorders, and then oncology, which is a study of more solid tumors. So medical oncologists and surgeons often work hand in hand to either give medical options for treatment or surgical options, or sometimes the combination. And then there are other things that can be involved too, such as radiation for the care of the patient. So that's why I mentioned for GIST, that oftentimes patients are treated with medicine, sometimes they're treated with surgery, and sometimes they're treated with both. Like a medicine might be given to shrink a tumor to the point that it's more likely to be treated with surgery. So again, the recurring theme I was mentioning before is thinking about the different factors to consider when taking care of a patient and thinking about these alternatives. The age of the patient. Again, this is going to be important. If you have a potential medicine that you can give a patient that will help him or her and it's safe, that might be a better option in an individual person than putting them through the potential risks of a surgery, which include anesthesia, hospitalization, and all the things that happen around the time of surgery. The clinical condition, again, is a patient very sick? Are they fairly healthy? The size of the tumor is important in GISTs because smaller tumors might be completely removed with surgery and larger tumors might not. And so you might still go through the whole process of doing a surgery, but the likelihood of cure might be lower the bigger the tumor. The question of how aggressive the tumor is important as well. And doctors can actually test for this using these special types of tests to see how rapidly are the cells dividing. And they can look at that under the microscope and make that determination. So all of this is relevant. Also, is the tumor growing, for example? Has a person followed this tumor over a period of time? That's called surveillance, when you look at it in one period of time and compare it to another period of time. And then ultimately has a tumor spread. So you'll hear about staging for a specific type of tumor, and that's when you do CAT scans or other types of tests to see if the tumor is confined to a specific area, like the stomach, or has it spread anywhere else, like the liver or the lymph nodes. So one very important alternative to surgery in a patient with a GIST is a type of medication that really targets the underlying cause of the tumor. And this is called imatinib, and the brand name is called Gleevec. And you might have heard about this over the last several years because it was quite newsworthy. Because this was one of the first drugs that really targeted the type of tumor that is growing. You know, one of the challenges with chemotherapy often is that you give a person a treatment and it kills all sorts of cells, good cells, bad cells. And that's one of the challenges because while you're doing your best to treat the person and kill that bad tumor, you know, oftentimes digestive cells are killed because they're rapidly dividing. So chemotherapies often target rapidly dividing cells like hair cells or GI tract cells. And that's why people get hair loss, diarrhea, and all sorts of digestive problems. But this is a drug that really targets a very specific type of mechanism inside the tumor that's causing it to grow. And it's called a tyrosine kinase inhibitor. And it's actually an oral pill, unlike going to an infusion center or other types of cancer treatment. And just because it's an oral pill doesn't mean it doesn't have side effects. I mean, there are potential side effects with any drug, particularly these types of drugs. And people can have significant side effects for sure. And these drugs can be very expensive. And the reason I mentioned that you might have heard of this is because there has been a lot of information in the press for patients on healthcare. Obviously, we're in an area of a lot of newsworthy events in healthcare, such as healthcare reform, et cetera. And this Time magazine article highlighted Gleevec because of it being one of the first kind of medications that we really understood what it did, and we really understood the type of tumor it would target. And so that's why I kind of wanted to mention it as an alternative to surgery in a very specific type of disease state. So we'll keep moving down the GI tract, and we're going to focus on a case now involving the colon. And remember, the colon I mentioned before is the large intestine. So sometimes people use those terms interchangeably. Now we have an 85-year-old woman who comes to the doctor complaining of left lower quadrant abdominal pain. For the last 5 days, she mentions she feels feverish, and when she takes her temperature, it's 99 degrees. Now you might think, well, that doesn't seem like a very high temperature, but in someone who's 85, whose average temperature might be 97 degrees, that's actually important to know. So sometimes we make the mistake of saying, oh, this is not really an exciting temperature, but for this patient, that could be pretty bad. And on top of it all, she says she feels feverish. So again, it goes back to listening to the patient. And even if some of the objective information doesn't really alarm a person, you have to really take a good history again and get a sense of how uncomfortable this patient is. So she says that the pain is 4 out of 10 in intensity. And so this is actually a useful tool using a pain score. And sometimes if there's a language barrier, you can actually just point to a visual analog scale where patients can see like a patient smiling or a patient in agony and say, I'm having that pain, especially if they're unable to kind of give you a proper history. So for this person, 10 is the worst pain she can possibly imagine, and she says her pain's a 4. So it's not really quite in that extreme range, and she didn't go to the emergency room. She just came to see the doctor. So as a doctor, you're reviewing her history, and you see that she had a colonoscopy 4 years ago, and she did not have any colon polyps, but she had sigmoid colon diverticulosis. And so we'll talk about what that is. So that might kind of give you an idea of this person could be susceptible to a condition in that area. And she hasn't had any evidence of bleeding. And that's just relevant because sometimes these things can bleed, and I'll tell you what they are. So what is diverticulosis? So diverticulosis is a condition where a patient can develop small pockets in the lining of the colon that can be seen when you're doing a colonoscopy, or they can be seen on an X-ray or CT scan. And I often kind of describe these as potholes in the road. So if you're driving along this road of the colon, you have these potholes. And I know in Los Angeles, we never have potholes, so you might not know what a pothole is. But in other cities, they have potholes. And if something gets trapped in one of those potholes, like your tire or stool or a seed, it can actually cause a local infection in that area, and that's called diverticulitis. So we'll talk about that, what that is. But just think about potholes in the road, okay? And I think it's, and many times when we do colonoscopy, because they're not concerning findings, people will forget they've been told by the doctor that they had diverticulosis. They say, oh, I didn't have any polyps, it was normal. But these findings are important to note because the doctor can then think in the future, if they develop a certain kind of symptom, that there might be something relevant there. So where's the sigmoid colon? So this is the large intestine, and the sigmoid colon is towards the end. So this is actually technically the beginning of the colon. Okay, the beginning of the colon is the ascending colon, and the small intestine attaches to the ascending colon. And this is the appendix kind of dangling off the very beginning of the colon, which is called the cecum. Then it's the ascending colon, the transverse colon, the descending colon, and then the sigmoid colon, and then ultimately the rectum. The rectum is really the very last part of the large intestine. And the sigmoid colon is one of the most common sites for diverticulosis. It's also one of the most common sites for colorectal polyps, which are the things we try to remove so they don't have a chance to turn into cancer. So ultimately, our patient in case number 3 had diverticulitis. And like I mentioned before, it's different than having diverticulosis. And we've heard these terms so much that oftentimes patients will call and say, well, I noticed in my colonoscopy report you said I had diverticulitis. I say, no, I said you had diverticulosis. But then we go back and forth about what that means. But the reason I mention it is because it's important for them and their doctors to know in the report. So if they ever present like our patient here, the doctor can actually think, okay, well, what are the possibilities for that patient? Remember when you're thinking about the differential diagnosis? If a person recently had a colonoscopy and we know that they have diverticulosis, then that gets higher up on your differential diagnosis. If they've had a colonoscopy and there was no mention of diverticulosis, or on a CAT scan we don't see that, it might be lower on your differential diagnosis, although you could still not see all the little pockets when you're doing a procedure. But diverticulosis is very common. A great majority of adults over the age of 70 have some of these little pockets. So although, yes, they could be basically make a patient susceptible to having diverticulitis, we don't typically think of it as pathology or something we need to warn patients about, unless they've had one of these episodes. So only a small fraction of patients in this great big world of all these people who have diverticulosis actually get this infection that requires treatment. So a lot of patients wonder, like, do I need to do anything differently? And we'll talk about it. But only a fraction of patients actually get diverticulitis. And it's typically a microscopic or localized infection in one of those little pockets. And that can lead to more significant issues, but typically a patient presents with pain, sometimes with fever, just general discomfort and not feeling well, and sometimes tenderness to the touch on examination. So pain, as first-year medical students, you should know this, pain is what the patient says, but tenderness is what you actually kind of elicit on an examination. So if you push on someone's abdomen and they're having discomfort and they say, ow, that hurts, that's tenderness. But what the patient tells you is, I'm having pain. So it's just, it's part of the language of medicine. So abscess formation, abscess is like a pocket of white blood cells that develops. I know it sounds like a really disgusting thing, but here you're in medical school now, so we'll get over it. So abscess formation can develop, actually these little tiny micro abscesses can develop into big pockets of pus, essentially, that need to be drained if antibiotics are not effective. So once you have a pocket, a closed off pocket of an infection, sometimes antibiotics by themselves might not be adequate. So again, what causes diverticulitis is when one of these openings, we described one of these little potholes, actually gets obstructed. And this could be stool or anything else that's in the GI tract, which is one of the reasons why for many, many years people would say, don't eat popcorn, don't eat seeds, don't eat nuts. And I'll talk to you a little bit about that. We don't really have, again, thinking about evidence-based medicine, we don't really have a lot of evidence to say that that actually makes a difference. A large study has been done looking at patients who have diverticulosis and looking to see the people who totally avoided those foods versus people who actually ate a normal diet, and there was no difference between these large groups. But intuitively, it makes sense. So that's why we say it. but now if we're going to use evidence-based medicine, we have to tell patients, it might not make a big difference, but some patients know that I eat this and I get these attacks. So if that's the case, you got to listen to the patient. So again, factors to consider when treating a patient with diverticulitis: the age of the patient. I mentioned that several times, but it is relevant. And typically, younger patients in their 20s and 30s won't actually get diverticulitis. I mean, it's unusual, it can develop certainly, but they don't usually have these pockets to begin with. So again, thinking about the condition of the patient. So if this patient was in the outpatient setting, we would probably try oral antibiotics. If they weren't getting better, they might have to come to the hospital and we would give them intravenous antibiotics. Think about, has this happened before? So if the patient keeps having episodes of diverticulitis several times a year, it might suggest that there's something about that area of the anatomy it's constantly causing things to get infected. Either that, or it's kind of like a campfire that's not completely extinguished. So you walk away from it and it can develop into a forest fire, okay? So that patient might need a more definitive treatment. And so you got to factor in, when was the last time they had an episode? Have they tried oral antibiotics? And we often are told by patients who come that I've been told I need surgery for my diverticulitis. Who should I have surgery with? And so you have to say, well, okay, before we get into the surgery, let's talk about, was this in fact diverticulitis? What happened the last time? And they'll say, well, I had 4 hours of pain and then everything went away. So if it's really that self-limited, just goes away on its own, probably wasn't diverticulitis. So, I mean, it could be all sorts of different things. Could be gas, could be other things like spasm that can cause pain. So really, again, it goes back to this history and physical, and taking a very careful history and getting an understanding of what you think is actually going on in that patient before you start thinking about surgery. Because, for an experienced surgeon, they can go in and do surgery. But again, it goes through all those things we talked about before. Do you want to put somebody through the risks of surgery if it's not appropriate? So there are a lot of alternatives. First of all, for uncomplicated diverticulitis, so a patient who doesn't have an abscess, doesn't have one of these more critical situations, they typically respond to oral antibiotics. And usually it's a combination of treatment aimed at very specific type of bacteria. So when we classify bacteria, we're looking at different things like how do they grow on the dish in the microbiology lab? Are they gram-negative bacteria? Are they gram-positive bacteria? Are they anaerobic, which means they grow without oxygen present? So typically gastrointestinal infections are gram-negative or anaerobic, but you can have gram-positive infections as well. And doctors may prescribe a course of 7 to 14 days or sometimes even longer depending on the diagnosis or the type of diverticulitis. And again, like I said, some patients need to come to the emergency room and actually get intravenous antibiotics in the hospital. So I mentioned before, you can actually develop an abscess, and sometimes when an abscess develops, then additional treatment is needed that might be beyond just medicine, but that's still not quite surgery. So we'll talk about what that is. So you can actually get drainage through the skin. A patient can get drainage through the skin. That's called percutaneous drainage to go into that abscess, drain the fluid, and then give the patient antibiotics. So if there's a pocket of infection and it's not being addressed, antibiotics alone might not actually penetrate into that area. So even if you have antibiotics going through the bloodstream in the intravenous route, it might not help. So that's why sometimes it's a hybrid between a surgery and a medical intervention. Diverticulitis can reoccur. So again, when it happens to a patient over and over again, we have to start thinking, is this patient actually going to be able to be taken care of without a definitive surgery? Because there might be something about that anatomy in that area, or those little pockets, sometimes they're referred to as ticks, those diverticula, in that area, maybe there's been scarring or something like that that doesn't allow stool or contents to freely move through there, so they keep getting infected. So, ultimately it would be great if we could actually prevent episodes of diverticulitis. But again, the evidence base is somewhat questionable when it comes to this. We used to tell people, again, don't eat nuts, seeds, popcorn, but we don't have a lot of data for that. And sometimes patients are constipated, which leads to diverticulitis. And other times patients say, no, I went multiple times in the preceding weeks, never had episodes of constipation. I mean, it makes sense to think, okay, well, if you're driving through the road quickly, you're going to drive right over the pothole. If you're driving really slowly, your tire's going to get stuck in the pothole. But again, if we're going to focus on the evidence base, we don't have much information. So we really have to think about the individual patient. So patients, you'd be surprised how much patients really love popcorn and peanuts. So when you tell a person that they can eat these things, if they don't have allergies, of course, then they're very happy. So again, I mean, the main thing is that we don't have much in the way of prevention. But if a patient has recurrent episodes that fit a certain pattern, it's reasonable to use avoidance. So we've talked about 3 different kinds of cases, and we've talked about decision making. We've talked about how to personalize things for individual patients. But really, I think the take home here is thinking about all the different alternatives and weighing risks, benefits, and alternatives for patients. You have to put the individual front and center when making a decision. Oftentimes, as a burgeoning healthcare provider, you realize that patients will come with their own experiences or family experiences, and you have to kind of sometimes wade through some of that and decide what's best for an individual. There could be both medical and surgical options, like in the case of the GIST we talked about. Oftentimes, medicine is started first and then surgery. Personalized medicine is a big buzzword. You're going to see the words personalized medicine all over the place in the coming years, because now we can test for genetic susceptibility for a patient prior to giving them a medicine. So that's really super personalized medicine. But at the same time, we hope we've been practicing personalized medicine all these years by talking to the patient, getting an understanding of that person's beliefs and the factors in that person's life that can help make a decision for him or her. And like I said, you really have to think about the risks, benefits, and alternatives. So I've left plenty of time for questions and answers. This is our website for the Digestive Diseases Division, and I'm happy to take any questions.